Good morning, everyone. It's Lana. Welcome to our final Fall Prevention Community of Practice. It's hard to believe it's already December 19th and Christmas is fast approaching. I believe I have everyone muted, but I would like to just kind of go through our next slide. Just take a look, make sure your phone's muted, and we want to make sure we're not on hold to prevent any background noise from today's presentation. We also want to encourage questions and discussion, so we can utilize the chat box. We'll be monitoring that, so please feel free to utilize the chat box today during our presentation. Today I'd like to change things up a little bit and have you utilize some chat now. And I'm going to ask about who's in the room, but today I'm going to ask for you just to comment. Take a minute, type in the chat box about how is your pharmacist engaged in fall prevention at your facility. Maybe there are some of your pharmacists that do a full review of each fall by conducting that medication review. Is your pharmacist engaged following a referral process for medication review? Is your pharmacist on your fall prevention team? So please take a moment just to put some notations in the chat box for us, and we're going to take a look at that and just see what everyone has documented, how you're using your pharmacist for preventing falls. I'm going to give you another moment just to go ahead and respond with a comment about how your pharmacist is engaged in fall prevention. I know that I work with one hospital, and their pharmacist does all of their discharge planning education for specifically to the medications that the patient is going to be discharged home on. So that in itself is a great method in order to prevent falls. Today, the title of our project is on taking a stand to prevent falls. We have the opportunity and the privilege today to have Sarah Durr, who is our Iowa Healthcare Collaborative staff pharmacist, present to provide this informational webinar today. Sarah is very engaged within our HIN, not only in our falls prevention work, but in the opioid projects and readmissions work. I would like to take this opportunity to welcome Sarah to our platform today. Thank you, Sarah, for having the time to share with us.
Thank you, Lana. I'm excited to be with you all today. Can you hear me okay?
I can hear you great. Thank you.
Thank you. So today I just wanted to take some time to talk about falls. We all know that this can be a difficult thing at times in the hospital and something that's so important to prevent injury or further issues for our patients when they are already in the hospital, probably in pain or uncomfortable or those sort of pieces. So we'll talk a little bit about falls prevention today. Next slide, please. So our objectives today are to discuss the tools that are available to evaluate a patient's risk for falls. We'll provide some information on actual prevention of falls. We'll identify medications that can cause falls and which ones we need to be paying more close attention to. We will talk about recognizing different drug interactions that can increase the risk of falls, and we'll also look at some disease states that can increase the risk for falls as well. Next slide. We'll start off with talking a little bit about the prevention of falls. So first and foremost, what is a fall? What's considered a fall? I think most of us are pretty familiar with this, but just to give a little bit of background before we dive into kind of the deeper content here, a fall is anything that is an unintended landing on a ground or another hard surface. So this includes things like slips, trips, or falls. So it could include somebody even slipping and actually hitting their arm or their head or anything like that on a table in the room or any other hard surface. So it doesn't necessarily mean that they have to go down on the ground, but any hard surface is also included within what the definition of a fall is. So think of that definition as we go through today's presentation. Next slide. So one of the biggest questions I get when I talk to hospitals or any clinicians around falls is, are they really preventable? Is there something I can be doing in my institution to prevent falls from occurring? And the answer is yes. And largely, falls are actually preventable. And we'll talk about those strategies to prevent falls today. We'll talk about different medications that can contribute to falls and what we really need to be paying attention to in order to prevent falls from happening in the hospital and even when a patient goes home. Some of the things that we need to be asking them and questions that they need to be aware of, how to answer those questions to prevent falls when they do go home. Next slide. So I want to start off first and foremost with the fall risk factors. So the big things that we need to be considering before we even dive into evaluating a patient for a fall or how to prevent falls. So first and foremost, the biggest risk is physical risk factors. So this could be changes in the body that increase the risk for falls. And we'll talk a little bit about the different disease states that actually increase the risk for falls and why that is. But it could even be we're administering a medication while a patient is inpatient, and that changes the way that their body is actually functioning. And so they could have some dizziness, they could be a little bit more lethargic or tired. And so that's a physical risk that we need to be aware of. What is going on with our patients and what are those physical risks? Additionally, I would add that a physical risk can be something that a patient doesn't necessarily come in with that risk factor, but they may develop that while they are inpatient. So things like developing hypotension, they could have a lower blood pressure due to what is happening while they're in the hospital, and that can increase their risk for falls. Behavioral risk factors are another thing that we need to consider. So activities that can increase the risk for falls. Is a patient needing to use the bathroom several times during the day and needing to get out of bed and go to the bathroom frequently? That can be something that is a behavior, or it could be a patient wants to get up and get into their personal items, things like that, just different behaviors that we need to be aware of. Environmental risk factors are things that are hazards in the home, hospital, or community that increase the risk for tripping or falling. So this is always the one that I think of around, do we have wet floors? Do we have different wires or plugins running along the floor? Do we have a guardrail on the bed to help prevent the patient from rolling out of the bed? All of those things that we need to consider, and even down to if we have slippers for the patient to wear when they do get out of bed, do they have that non-slip surface? All of those pieces are really something we need to think about. Most falls are actually a result of a number of these different risk factors, and so not just one of these is necessarily at play. We need to think about the fact that it does cross-cut through all of these different risk factors. So that's an important thing to keep in mind, is it might be that a patient has low blood pressure and slippery socks on, and that combination ends up having them have a fall. So thinking through the different areas is helpful, but also knowing that all these happen throughout. So the key questions to think about when you're thinking about detecting the fall risk, and we'll go through a couple of different tools to help us detect fall risk. But first question you should ask is, has the patient had a fall in the past year? If they've had a fall in the past year, it is more likely that they will have an additional fall this year. So we need to take extra precautions to help prevent that fall. If they did have a fall in the last year, were they hurt? Did they hit their head? Did they end up having a gash on their arm? Did they end up bruised? All of those pieces are things that we need to ask them around if they ended up getting hurt. Asking a patient, do you worry about falling, can be a really good indicator on if they have concerns. That can actually bring up some good discussion around if they have dizziness or if they feel uneasy. All of those pieces, or even if they feel like their legs might give out because they have weak muscles or they have osteoporosis. Those are all pieces that really can come out of asking that one question. Another question to ask the patient is, do you feel unsteady when standing or walking? And again, that can be contributed to osteoporosis, weak muscles, any of those pieces. And then lastly, do you limit your activities due to the fear for falling? That can be a really important one when a patient does go home. simply because that is something that we want to make sure they're still active and able to live their lives. But if they are too fearful of falling that they are actually limiting their activities, then we need to be evaluating that and making sure that we're treating that appropriately. Next slide. So like I said, there are multiple chronic conditions that can contribute to falls or potentially have an increased risk of a patient falling. One of those is diabetes, and when I think about diabetes, I think about low blood sugars. So maybe the patient has taken too much insulin, or maybe we have or treated the patient with insulin. That can absolutely lead to some dizziness and an increased risk in falling. So diabetes is something to keep in the front of your mind when it comes to falls. Arthritis is another one. Pain in the joints and pain in the knees and hips especially can contribute to falls. And so arthritis is one that I think of when it comes to chronic conditions that can contribute to falls. A stroke, if the patient has had a stroke, they're more likely to fall and be at a higher risk of falls. So if your patient is in the hospital for a stroke, definitely keeping the fall risk in mind is important. Multiple sclerosis, again, is another one that's contributed to the pain, and just the disease state itself increases the risk for falls. Parkinson's disease, with the shakiness, it can also cause gait issues. And so when we're looking at Parkinson's disease, that can absolutely be one that has an increased risk of falls. Chronic pain is another one. So anytime a patient has pain, they are at a higher risk of falling simply because they can have something give out when they're trying to get up and move, or they could be in so much pain that maybe they grab their back and that makes them a little unsteady, and so they fall. Depression actually increases the risk for falls, and a lot of that can be contributed just to having lower awareness about what they're really doing, or they're just really down in the dumps and not thinking through if this is safe for them to do. COPD is a big one, especially because a patient could have some trouble breathing, and that can lead to dizziness. That can also lead to them falling because they may have a little bit of the dizziness that contributes to kind of having that blackout moment where they end up going down on the ground. Same thing with asthma, so making sure that we have appropriate use of inhalers in both of those. And then heart disease is a big one. So heart disease is one that I always think of when it comes to fall risk because of the low blood pressure that we can see. Next slide. So like I said, blood pressure is a good indicator of fall risk. It's important to keep our blood pressure in the normal range for both our systolic and diastolic, and that is to prevent having low blood pressure, especially around when we're looking at falls. There's something called postural hypotension, which can increase the risk of the fall, and this is when a patient goes from laying down to standing or sitting to standing too quickly, and they can have a drop in their blood pressure just from that movement. So evaluating a patient by taking their blood pressure when they're sitting, and then again when they stand, we can detect if they have postural hypotension, and then take measures such as telling the patient to take it a little bit slower when they go from sitting to standing or from laying down to sitting, so that they don't have quite that drop in blood pressure, and making sure that they have proper gear in place, such as a rail or things like that on the bed to help them, so that if they do get a little bit dizzy, they have that to grab onto. And hypertension can also lead to headaches and vision changes, and that can lead to an increased risk in falls. So thinking about if you have high blood pressure too, you can get really bad headaches, or you can have vision changes, so they may not have the same depth perception to help them when they are up and walking around. Next slide. So next, let's talk about prevention specifically in the hospitals. Next slide. So one of the best resources I have found when it comes to looking at falls, and a great way for hospitals to come together and look at how they can improve the fall or decrease and improve their falls programs in the hospital, is the Agency for Healthcare Research and Quality, so AHRQ. And I do have the link on this in this slide so that you can go and visit this tool and see how you can implement this into your hospital. Basically what AHRQ has is a toolkit for improving quality of care. This toolkit has a variety of different resources for you. It's got a lot of great information, and it walks you through actually implementing a falls program in your hospital. And this can also be a great tool if you do already have a falls program in place to evaluate to see if there are gaps in your program that you can fill and further improve that program. So one of the first things it has is it includes steps to take to implement changes in your facility. So like I said, either developing that falls program or enhancing the program you already have in place. Next, it has some information on how to measure fall rates and how you can do fall prevention. So there's a lot of great resources in there around how do you actually measure the number of falls that are happening in the hospital, as well as how do you actually prevent them. Once you have a prevention plan in place, there's some information on how to sustain an effective fall prevention program. So not just putting it in place, but making sure to go back and evaluate it, but it is effective, it is sustainable, and it is something that's happening on a regular basis. It's very easy in healthcare to put a program together and then move on to the next one and not come back and evaluate that initial program. We have so much coming at us every single day, especially in the hospital setting, that we need to make sure we're actually going back and evaluating and setting timelines to do that on a regular basis. And like I said, there's a lot of great tools and resources, so definitely check out that website if you have not done so already. One of the biggest and most important pieces in creating a program and sustaining an effective program is having that team consensus. So the first step that we take when we actually implement a falls program or go back and evaluate what we've already done is making sure to reach team consensus on the following questions. The first one is, which fall prevention practice should you use? We will talk about multiple different things that we need to consider with falls, how we do a risk assessment, what medications look like on some slides later on, but really looking at what prevention practice works for our hospital. And what works for one hospital doesn't necessarily work for the next. So keeping in mind what you have at your fingertips for resources, who your staff is, and then evaluating the different types of prevention practices to determine what's best for you. And it could be that your sister hospital or whoever you work with very closely might have a program that you can pull some bits and pieces from that work well for your hospital, and then maybe another hospital nearby you can pull some bits and pieces from to really create the program that fits your hospital. The next question is, which universal falls precautions should be applied throughout the hospital? So again, going back to that toolkit from AHRQ and looking at what are the different precautions we can put in place and what is feasible for us to do here in our hospital. How should you standardize assessment of fall risk factors and how do you conduct that? It's really important that you choose the assessment that is best to you. And we will actually look at a couple of them that AHRQ has said are the best ones and the ones that have been the most studied. But again, sometimes hospitals create their own fall risk assessment because that's what works for them, and that's okay. How should I identify risk factors to be used for fall prevention care planning? This is a big one. So not only identifying the risk factors, but then how do you actually put a care plan together to help prevent that fall? So this could be that you note a patient has postural hypotension. And so we want to talk to the patient in the care plan and say, we want you to take it easy when you're getting out of bed. And then evaluating, do they have obstacles in their way to get to the bathroom? Do they have the correct slippers or socks so that they are not slipping and falling? Do we have a bed rail so that if they do need to grab onto something because they're dizzy, they have that available? And removing any of the obstacles that may end up leading to a fall. And creating that care plan to not only share with the team that is caring for that patient, but to share with the patient so that the patient recognizes that these are some actions they need to take. How should you assess and manage patients after a fall? So if we do have a fall that unfortunately happens in the hospital, how do we assess that patient to see if they still have a risk for fall? And then how do we really manage that patient to prevent the fall? And the biggest thing here when we do ask that question is making sure that we actually have a plan in place if a fall happens. And if it's from postural hypotension, we know exactly how we're going to handle that. If it's from hypertension, how are we going to handle that? If it's because they had slippery socks, how are we going to handle that? So having all of those pieces in place to know what the next steps would be if a fall did occur. And the last team consensus question is, how can your hospital incorporate these practices into a fall prevention program? So really actually setting up the stage of how that program looks is going to be very important in order to prevent falls in the hospital. Next slide. So some key points when you do go ahead and implement this plan after you have team consensus that we want to make sure this implementation happens is, first and foremost, fall prevention must be balanced with other priorities for the patient. As I've alluded to earlier, we have so much going on in the hospital, so many different things that we're trying to manage, that a fall may not be the #1 thing that we need to do for a trauma patient. Or looking at prevention of falls may not be the #1 thing that we need to do if a patient's in a coma. So really making sure that it makes sense for us to be evaluating that fall risk for that patient. Second thing is that fall prevention must be balanced with the need to mobilize the patient. So we don't want to evaluate the patient and say, you know, they actually are at a really high risk for a fall, so I'm just going to have them stay in bed. I'm not going to have them get out of bed all day. That's not healthy either, because that can lead to pressure ulcers, that can lead to depression, all of those pieces, and it can make the patient not feel as activated to do what they need to do on a daily basis. So making sure that we are balancing it with, do they need to walk to the bathroom? Should they be going for a walk every day to help strengthen their muscles? So really looking at those mobilization needs as well. Fall prevention is one of many activities needed to protect patients from harm. So we can't ignore all the other activities that we have going on in the hospital to prevent harm and only focus on falls, but really integrating that with all the other activities that we have occurring in our hospital. Fall prevention is interdisciplinary. I love that Lana asked about what you all do with your pharmacists around fall preventions, and we had a couple of people respond in the chat, so thank you for sharing that information. Pharmacists definitely do review all medications on admissions and complete discharge education on medications. That's amazing, Kathy. That is what we should have happening, not only to look at fall prevention, but also to detect any other issues. Pharmacists are a wealth of knowledge around all the different medications and how those interact with the disease states, with each other, and all of those pieces. So absolutely pulling your pharmacist in is important. But we also need to have our frontline staff on board with any fall prevention projects that we're doing. If they're not on board, then we're not necessarily doing the risk assessment, actually putting in the prevention steps. So it's important that we're including the full team when we do talk about fall prevention. And then fall prevention needs to be customized. As we've said, it needs to be balanced with other priorities for the patients and with mobilization. Every patient's going to be a little bit different on what they need when it comes to customization. And that simply is because of their history, if they've had a fall, their disease states, their medications, and then as a person and their needs. So making sure that we do customize that for each patient is a key part of actual implementation. Next slide. So some universal fall precautions that we can take that most hospitals are implementing and what AHRQ suggests is, first and foremost, familiarize the patient with the environment. Help them know where they need to go, what's available to them. If there are trip risks, like cords or things like that on the floor, helping them know that they're there can assist them in not having that fall. Having the call light within reach is a very important piece. That way a patient doesn't have to get out of bed if they're not feeling well, especially if they have low or high blood pressure or other things happening that could increase their risk of falls. It's really important that that call light is nearby so that they're not trying to reach for it if it's away from the bed. Keeping personal possessions within reach. This is something that is important, but we also don't necessarily have to keep every single thing that they have with them right next to the bed, but making sure the ones that they use on a regular basis are available to them near their bedside and easy for them to reach. Keeping the hospital bed in the lower position and locked is a big one. If the bed is not locked, there is a much higher risk of them falling because that bed will move when they try to get up. And additionally, if it's too high, they may have to jump down. For me, I know I'm a shorter woman, and so I'm about 5'2". And if the bed is too high, I may have to jump down, and that could increase my risk of falls. So making sure that we have that at the appropriate height for the patient, again, customizing that to the patient. Keep non-slip, comfortable, well-fitting footwear on the patient. So we've talked about slippers or socks and making sure that they have that non-slip surface so it doesn't cause them to fall. Using night lights or supplemental lighting. This is huge in the hospital. If a patient does need to get up at night to use the bathroom, making sure that they have light to see where they are going. And that even goes for when the patient goes home, suggesting that they utilize night lights or supplemental lighting to get to and from their bedroom or their bed to the bathroom or wherever they may go in the middle of the night. So just a key piece to even think about in discharge planning as well. Keeping floor surfaces clean and dry. So again, this is an interdisciplinary team. We do need to pull our janitorial staff even in on this to make sure that we are appropriately cleaning and not leaving spills or having wet surfaces that a patient could fall on. And then keeping patients' areas uncluttered. So again, free of cords running across the floor or any other things that may be in the room that they could trip over and cause a fall. Next slide. So let's talk a little bit about evaluating the fall risk. Next slide. So fall risk assessments. Why is a standardized risk assessment necessary? Like I said, there's a few out there that we will talk about that AHRQ has actually said that these are the best ones to utilize, but hospitals oftentimes will create their own fall risk assessment based off of some of these other standardized scales. It is important in the hospital that you do have a standardized risk assessment that the hospital is using so that it is hospital-wide, and you can really make that clinical decision when you need to. It allows for targeting of preventative interventions to the correct patient. So if that is standardized, you can have this patient's at this risk, here are the interventions we need to take, and it's much more smooth if you have that standardized assessment. Facilitating care planning, that's a big piece too, so that we can customize it and can make it unique for each individual to prevent falls. And then it also helps with communication. If we have a bunch of different types of risk assessments, it's going to be much more difficult for the facility or the interdisciplinary teams to communicate, especially upon shift changes. So making sure that we do have that standardized assessment is key. Next slide. So how to perform the assessment. There's a lot of key pieces to this, and we'll walk through two big risk assessment scales that AHRQ endorses. But this is kind of something to think about if you do end up creating your own. These pieces are things to consider. So history of falls, assessing the risk of having another fall. Have they fallen in the last year? Were they hurt when they fell? All of those pieces can help you know if they're low, medium, or high risk just from the history of falls. Mobility problems. So if a patient has assisted devices, is there a risk if they are in a wheelchair of getting up and potentially having that slide out from under them and having them fall? If they're using a cane or other mobile devices, thinking through what could potentially happen to make sure that we do reduce that risk of falls. Medication is a big one, and obviously this is where your pharmacist can come in, but there are many medications that can cause an increased risk for falls, and we'll talk about how to identify those medications a little bit later on. Mental status, so delirium, dementia, psychosis can all increase their risk of falling, and that's something we need to identify and make sure that we are addressing appropriately in that assessment. Continence, do they need to get to the bathroom frequently? If they are running to the bathroom frequently, that can increase the risk of falls. So very important that we evaluate that up front. And then other risks to consider, are they actually tethered to some equipment? Do they need to have that IV bag with them at all times? And what could potentially increase the risk of falls by having that with them? Do they have some vision issues? That's another thing to think about. And then that orthostatic hypotension or postural hypotension is definitely something to consider. So great, we have this assessment, we know we're going to use it. When in the world do we actually put this into place? Well, definitely upon admission, we want to make sure that we are assessing the patient's risk and know what that risk is up front and what interventions we need to put into place. If there's a transfer from one unit to another, it's a good idea to do a falls risk assessment. There's a reason they transferred, and it could be a change in their status that could increase their risk of falling. So making sure we do that. And then again, with significant changes in the patient's condition, so if they were hypotensive and then all of a sudden they become hypertensive, or those pieces, making sure that we do look at any change in their condition to actually do that assessment again. And then, of course, after a fall, we want to do that assessment. And it could even be beneficial to do that assessment upon discharge if we do have concerns for falling, to help the patient know what to do at home so that they do not fall once they get home. Next slide. So like I've alluded to so far, there are a couple of fall risk assessments that AHRQ has endorsed, and the two are the Morse Fall Scale and Stratify. So let's start with the Morse one first. It is made up of 6 subscales, so history of falls, secondary diagnosis, ambulatory aid, IV heparin lock, gait and mental status. And I do have the website there for that one, and I will add the Stratify website for the PDF before we post these slides to Innovation, so that you do have that information. But you can also find it on the AHRQ Falls Hospital Toolkit. So with the Morse scale, I think the interesting thing with this one is it is a 25-point scale. Excuse me, it is a 51-point scale. And it really looks at the likelihood of falling. And so many nurses have actually said, 82.9% rate this scale as quick and easy to use. 54% estimated that it took less than 3 minutes to rate the patient. And the consistency of the 6 variables really make it easy to score, and it helps with the predictable level of fall. So it's definitely a great scale to use. The questions that they ask really are, have you had a history of falling within the last 3 months? Yes or no? If it's yes, there's 25 points assigned to it. Is there a secondary diagnosis like hypotension, hypertension, diabetes, those that we went through that could cause a fall? If yes, 15 points. If they're using a bed rest or nurse assist in ambulatory aid, crutches, cane, or walker have a certain amount, or if they're actually using a wheelchair, they have a 30-point scale there. If they are using heparin or an IV, then yes, they're going to have a little bit more points at 20. If they have trouble with transferring and need some assistance, so those pieces are also rated on a 20-point scale. And then mental status. Do they know where they are? Do they know their own abilities, or do they forget their limits? And that's assessed there. So the scale that I have for that website there really walks you through how to ask all of these questions, how to score these questions, and then it actually has the risk level on the bottom to know exactly what to do. So if they're under 24 points, they have no risk, and they just need basic nursing care. If they are between 25 and 50, they're low risk, and so then you have the implement standard falls precaution interventions to make sure that the patient's not going to fall. And if they're above 51, then it's a high-risk patient, and we need to add some extra precautions to make sure that they do not fall. So that's the Morse Fall Scale, or the MFS, and that is available to you at that website. The other scale is the Stratify, and this has 5 subcategories that look at transfer and mobility, history of falls, vision, agitation, and toileting. So similar, but a little bit different. And it does lay out the questions for you of, did the patient present to the hospital with a fall, or have they fallen to submission? Is the patient agitated? Are they visually impaired? Are they frequent toileting? Do they need assistance with transfer or mobility? And then you score that up, and it lets you know if they are able to be low, moderate, or high risk. And so there's those quick questions that you go through, and you just score that up real quick, 1 to 5, pretty simple. So it's an easy one to use. AHRQ definitely finds some value in it, and I'll add that website so you guys have that PDF available to you once we post this to Innovation. Next slide. Let's talk a little bit about falls with medications. We absolutely encourage you to review medications as a part of your fall risk. Strategies for reviewing medications will depend a little bit on your hospital. If you can have a pharmacist involved, that's ideal. Otherwise, making sure that you have somebody who's very knowledgeable about medications and can utilize some of the tools that we'll talk through here. But yes, the pharmacist can definitely make recommendations on how we can reduce falls risk with medications. Next slide. So again, this is from the AHRQ toolkit. I thought this was extremely valuable to take just a quick glance at what can potentially have a higher risk of falls when it comes to medications. So high risk, we have analgesics, with the caveat that this includes opioids, as those can cause some sedation, antipsychotics, anticonvulsants, and then benzodiazepines. Although not included in the original scoring system within the toolkit, it is something you need to consider, as it does cause sedation. And like I said, those all can cause sedation, dizziness, postural hypotension, altered gait, and impaired cognition. At the medium level, we have antihypertensives, cardiac drugs, antiarrhythmics, antidepressants, can all cause that orthostatic hypotension, impaired cerebral perfusion, so actual blood flow to the brain, and then can decrease their health status. So something to think about on that medium level. And then low risk are diabetics, because that increases their ambulation, and they could have some more orthostasis with that. So definitely something to consider. And then on the bottom, they just have a score greater than 6. That just is talking about more of that risk for falling and how you evaluate that patient and what you need to look at. Next slide. Okay, so again, this is in the AHRQ, Preventing Falls, but things to think about when we're talking about fall risk evaluation. So back to thinking about that evaluation. If we're looking at medications, we need to take a look at that Beers criteria, and we will talk about that next. It truly is something that is a very useful resource, and they do have a pocket card that you can have to carry with you, and it's from the American Geriatric Society, so we'll talk a little bit about that. If there's a dose adjustment for renal function or other disease states, we'll absolutely need to evaluate falls. If we have too much medication in the patient, evaluating that fall risk, and then IV access, of course, is something to consider with the falls risk. When we look at laboratory, thinking about therapeutic drug levels, so especially around our digoxin, phenytoin, those pieces, we need to consider that when it comes to medication. Our INR, when we're looking at use of warfarin, is something we need to consider, as that can increase the bleed risk when a patient does fall and can lead to further issues down the road if there is a fall that happens. Electrolytes are really important when we look at laboratory values, simply because if they are out of balance, we could increase our risk for falls. And then our hemoglobin and hematocrit, again, looking at those from a piece of the bleed risk. So if that's not in the correct range, we can increase the risk if a fall does happen. We've already kind of talked about these disease states, but hypertension, congestive heart failure, diabetes, orthopedic surgery, if they previously had a fall, dementia, delirium, all those pieces can lead to an increased fall risk, so something we need to consider. And then, of course, education. What's the patient's ability and willingness to learn? And is it appropriate for them to look at the patient's mental status? Are they able to actually learn the information we need to share with them? And just a caveat, those over the age of 65 are actually at a higher risk of falling, so keeping that in mind when you do that evaluation. Next slide. Okay, so we've talked a little bit about the Beers criteria. They were developed in 2012. There was an initial one that came out from the American Geriatric Society, and since then it has been updated in 2015. You can access it at this website here, and I've also put the pocket guide there for you to access. I found when I was in practice that having the pocket guide was extremely useful. It was a quick, take a look at this, see if the medication is on there, and that way you don't have to memorize every single medication that's on the Beers criteria. Next slide. Okay, so this is a snapshot of kind of the intended use for the Beers criteria. Like I said, this was updated from the 2012 version, and it helps especially with the potential inappropriate medication use in older adults. This has been developed to really help healthcare providers improve medication safety in older adults and help with clinical decision-making when it comes to prescribing a medication for older adults to improve safety and care overall. So the criteria may not be applicable in all circumstances, especially if a patient is in palliative or hospice care. But if a clinician is not able to find an alternative and chooses to continue to use the drug on this list for that patient, then we just need to make sure we're recognizing what the concerns are with this. So the Beers criteria don't only cover falls risk, they cover a lot of other risks when it comes to our patients over the age of 65. And the goal with this is to be viewed as a guide to help identify those medications and looking at the benefits and risks and if it's appropriate for a patient to be on something. It's really meant to be helpful in clinical decision making and not meant to be punitive in nature. So keeping that in mind. And this list definitely doesn't supersede clinical judgment. We need to make sure that we're taking the patient's values into account and talk through all the different criteria around that. So again, customizing this for the patient. They do not underscore the importance of the team approach. So again, that interdisciplinary piece is very, very important. And then there are certain criteria such as stop-start criteria and medication appropriate indexes that you can also use in a complementary manner to the Beers criteria guide. So keeping that in mind that there are some other options out there to take a look at. Next slide. So this is just an example of what the Beers criteria look like, and I just pulled some ones that were looking more at falls risks. So looking at non-benzodiazepine, hypnotics, that's our zolpidem, kind of our sleep medication. Avoid that with chronic use in patients over the age of 65, simply because it can have an adverse effect, causing sleep latency, which can end up leading to falls. So they could still be very sleepy in the morning and can lead to them falling. So something to consider with the benzos or non-benzos, hypnotics. Benzos, of course, are something that we need to consider as well, as that can alter their kind of mental state and make them a more foggy, more lethargic, and so that can lead to falls as well. Insulin, especially if it's a sliding scale, we can monitor that much more closely in the hospital, but outpatient, we wouldn't necessarily want a patient over 65 going home on a sliding scale if it wasn't necessary. Again, that clinical judgment will come into play because there's a higher risk for hypoglycemia. And that's something that we just need to outweigh the risk versus benefit of getting that hyperglycemia and hypoglycemia. What is our risk versus benefit there? And then if they have a history of falls or fractures, things to avoid would be our anticonvulsants, antipsychotics, benzos, and then our non-benzo hypnotics or sleep medications, as well as our tricyclic antidepressants and our SSRIs as well. So avoid, if there's not a safer alternative, then we can do it, but especially not using those, as those can increase the risk for ataxia, which can cause them to fall. We can have syncope, which can lead to falls. So really looking at that risk versus benefit again. But this is a really helpful, useful resource to say, you shouldn't really be using these or avoid these because of this reason, and it helps you walk through that really well. So definitely recommend the Pocket Guide if you aren't already using it. Next slide. So some key drug-drug interactions, or drugs that do have a lot of interactions that we need to think about. All of these drugs on this slide can definitely increase the risk of a fall. So benzos are non-benzodiazepines or sedatives. Anticholinergics can increase the risk of a fall, and they have a lot of different interactions that can increase that risk. Antipsychotics and mood stabilizers, anticonvulsants, antidepressants, opioids, antihypertensives, and blood sugar medications. The thing that I want to underscore here, and actually the story I often share, is when I was in practice, I had an 82-year-old woman, and I was actually in the ambulatory care setting, so in the clinic, working one-on-one with patients. So I had an 82-year-old woman come to me, and she was on a benzodiazepine, an opioid, on a Z drug, so our non-benzodiazepine sleep drug, and a muscle relaxant at 82 years old. Obviously, there was some cognitive impairment. She had fallen several times. She just was not doing well overall. And we started working through how to get her off some of these medications and change to other medications. She had actually been diagnosed with dementia simply from the cognitive issues that we saw from all these medications. So as we got her off these medications, and we did wean her off all of them and went to safer alternatives, over the course of about 12 months, we actually saw a change in her mood. She was much happier. We saw her come out of that dementia state, as they had described it, and she was actually able to function much better. And she was able to prevent falls. So she had stopped having the number of falls that she had previously had in years before that. So definitely all those drug interactions made her even worse than if she had just been taking one of those medications for risks of falls. So something to keep in mind, and work with your pharmacist on how to prevent some of those drug-drug interactions that can lead to an increase in falls. Next slide. Again, kind of like I said, if there is a medication linked to falls, the things that we need to consider is, can we stop this medication? If we can, then we need to stop this medication. If we can't stop this medication necessarily because they need to have something in that class to treat a disease state, can we switch to a safer alternative? What's out there that we could potentially change to help prevent that risk of falls? And then if we can't necessarily switch to a safer alternative and we can't stop the medication, let's reduce it to the lowest effective dose. I know right now that the opioid crisis happening in the United States, that's one thing we talked a lot about, is how can we decrease to the lowest effective dose and not continue to amp up on this? What is actually tolerable for the patient? What are their goals? And how can we decrease to the lowest effective dose? So thinking through that is absolutely a big piece. Next slide. And with that, I'm happy to take any questions that you may have. Feel free to pop them into the chat function. And Lana, I don't know if you've had any come in on your side at this point, but I have not seen anything in the everyone piece.
No, Sarah, I don't have any questions at this point. So as you said, please, participants, go ahead and use the chat function if you have any questions for Sarah. I thought it was real interesting to give that overview of the Beers criteria. And honestly, I don't know if our participants today, because primarily we have quality and nursing people present on our webinar, if they even know if the Beers criteria is something that they're using in their hospitals. So think that's a great question to ask your pharmacist if they are using that for your patients 65 and older. And as we know, in our hospitals, we have an elder population. So it's a great question to ask. And Sarah, do you have anything else to offer at this point?
I think that's a really great point, Lana, is knowing if they're actually being utilized, and not even just from the pharmacist standpoint, but frontline staff can ask those questions too and say, this patient's at a higher risk for falls already. Should we change this medication? I think that's a great, great point to bring up with any hospital you're working with. Otherwise, I don't think I have anything else at this time. I'm happy to, of course, answer questions after this if folks have anything that comes up. And just know I'm here as a resource for you and the Compass PIN so that you all can have a pharmacist, and how do you work with a pharmacist. If you have those questions, I'm happy to answer any of those questions for you.
Thank you, Sarah. You've been a very good speaker for us today, and I know everyone truly appreciates your information. So thank you again.
Thank you for having me, Lana.
You're welcome. Let's talk a little bit about our fall prevention planning. I kind of want to give you all an update about what we're doing here for falls. As I indicated at the start, this is our last community of practice webinar that we're going to host for our fall prevention group. So right now, we are going to start working in the initial stages of planning for an actual summer program that I'm hoping to get finalized and share with the hospitals. But it's going to be where we're going to partner with a national fall patient safety leader, and we're going to be focusing on not only reducing falls in the hospital, but reducing fall injury. So I am very open to best meeting your needs when it comes to fall prevention. I am always available with a phone call or an email, but what would be best to meet your needs? I want you to think about that a little bit. What would be best to meet your needs in your hospital, and what ideas do you have that can promote a hen fall reduction program? Please just reach out via email to me, any thoughts that you may have. I'm very open to any of those as we begin our work and in planning. I want to just take a few moments as well to talk about what's upcoming. We've sent email alerts and different communications out to our hen hospitals about a couple of projects that are actually starting in January. We have the Refuel Readmission Project, and that is led by Kate Carpenter. And you can contact Kate via email. She had an informational webinar on that earlier this month. And so she is going to begin that project in January. And likewise, our January project for the Opioid Guardianship Project. It's the second project that the Opioid Guardianship has undertaken. Because of the success in the first one, they are continuing on. And Jennifer Kriegmer is the improvement advisor that is responsible for that. And she's working with Sarah Deere to work on that as well. So very exciting. Another project that we had sent out information, and we've got many hen hospitals already joining, is the ARC John Hopkins Antimicrobial Stewardship that starts also in January. So it is just all of these projects. And as we've talked before with many of our hospitals, we have moved from a webinar stance of providing education into action steps. So that is what we're doing, is presenting projects that we're working side by side with our hospital teams and getting things moving in your hospital. And we're hoping to drive that improvement through what we're offering. Another announcement I want to share is about office hours starting in 2018. We're going to resume office hours after the first of the year, and at this point we're looking at starting that every other month. Our hen program director, Jen Brockman, will be establishing that schedule and getting that information out to our hen hospitals. There was an email that came out about our patient safety conference that'll be held March 6th in Ankeny. And there is a link to sign up for that. That's going to be an all-day conference. We have some exciting information, but you can take a look at that link. But some of the pieces that we have we're going to be offering are going to be about some patient stories where we have patients sharing some information. We have an introduction to diagnostic error, which is a new program that we have that we're moving forward with. Stacy Klinker is actually going to be moving forward with that. And avoiding those superbugs through antimicrobial stewardship. There will be more information about combating the opioid crisis and also information on readmission. So I think it looks like a pretty exciting program, and of course we'll be announcing our safety award winners at that conference as well. And as we move on to our last slide, I just want you to again know, here I am available to you, ready to help you with your fall prevention work. I can do consultations, I do those on site, or I can do those by phone. Thank you all so much for participating in our webinar today, and happy holidays to all of you.